I request Dr. Vaisi Paul sir to introduce our honorable speaker and to take this very important CME on uric acid forward. Welcome sir. I just forget. Welcome to CME number 786.
Thank you, Dr. Chauhan. Thank you, Dr. Sanjeev Gulati. Thank you, Sun Pharma. And good evening, friends. I really feel honored to be moderating this 786th CME of Physicians Forum of India. And it's a special CME on a topic which is of day-to-day use. And we have two stalwarts of our profession with us today. The first talk will be by Dr. Sanjeev Gulati, who is the Principal Director and Head of Nephrology at Fortis Escorts and Fortis Vasantoj, both. He is the President-elect of Indian Nephrology Society and ex-Vice President of Indian Society of Organ Transplantation. He is also the Adjunct Professor at Kasturba Medical College and has been an Additional Professor at Sanjay Gandhi Postgraduate Institute of Medical Sciences. Most of these things everybody here knows. I'm going to tell you something which some of you might not be knowing. That apart from being a very good nephrologist, he's an excellent pediatrician also. After doing his graduation from Maulana Azad Medical College, he went to PGI Chandigarh. And it's from that prestigious institute that he did his MD in pediatrics, which was followed by a DNB in pediatrics, which was followed by a DNB in nephrology, and then he did his DM in nephrology. That we know. Before joining Fortis Group of Hospitals, he was an associate professor of pediatric nephrology at McMaster University, Hamilton, Ontario, Canada, right next to Niagara Falls. So, he is uniquely placed as far as treatment of children with renal disorders is concerned. He has more than 5,000 renal transplants to his honor, many of them in pediatric age group. He has more than 150 original research papers to his credit, and he has contributed to more than 50 chapters in textbooks of nephrology and pediatrics. So from this great master, today we will be learning about the relationship between uric acid and renal disorders. Please welcome him with a big round of applause. Thank you.
Thank you, Dr. Paul. I feel really humbled by this introduction. And it is always a pleasure to be in this forum, which I think this will be my 15th year of association. I haven't counted the number of CMEs, but Sushil might have the data. But it's a great learning experience for me, and I learned a lot of my diabetes, to be very honest, here in this forum. A lot of new things came up, and a lot of new nuts were introduced over this. But today's talk is something about which is the wheel has turned a full circle, and that's about uric acid and kidney disease, and we'll see how. So I'll start off with a story. In 8 December 2007, several ghadials were found dead, and it was suspected there were some illegal fishermen who were trying to, get the skin of the ghadials. But detailed 12 December 2007, more ghadials were found dead. It was then that the alarm bells rang, and finally the cause was revealed in January 2008, 2 months later, and we'll relook at that. Share with you an actual case. This was when I vanished at Fortis Vasantoj. A 41-year-old male who was hypertensive for 4 to 5 years. history of renal stones since last 4 to 5 years, came to me with a serum creatinine of 1.5, blood urea nitrogen of 12, uric acid 8.3, EGFR was 69 mils. So he had CKD stage 3 at least at that point of presentation, although you need more than one, but somebody had labeled as CKD, so I thought yes, might be having CKD. Urine was bland, ultrasound was normal, except for this calculus that was there. So what I did was, I looked at his uric acid level and I said, let's first try and fix that. So I put him on febuxostat, and sure enough, when he came to me a month later, I had to change my diagnosis. He was no longer at CKD. This was actually an acute kidney injury that had occurred, calling hyperuricemia. And as you can see, all the parameters had reversed just by this 40 milligram of febuxostat. One of the most happy customers I ever had, and recently more. And thereafter, he sees me once a year, normal renal functions till now. So I've divided my talk into 4 halves. We look at uric acid, then look at hyperuricemia consequences, look at the relationship with uric acid and chronic kidney disease, and lastly, look at uric acid, urate lowering therapies. So just to take you back to your physiology days, kidney plays actually a critical role in the excretion of uric acid. 70% of the uric acid that is produced daily is excreted by the kidneys and the rest is by the intestines. Uric acid is filtered at the glomerulus, reabsorbed, secreted again in the proximal tubule. So finally about 80% of the reabsorbed is uric acid is reabsorbed there, and about 10% of the filtered load finally finds its way down in the urine. So very extensive process, and that's why nephrologists are very closely involved in hyperuricemia. Now this is gout, as we know. So this is the uric acid levels, and you have the dietary urine load that contributes. You have also the endogenous urine synthesis, which is actually a greater contributor. And the predominant mode, as I said, is renal excretion. There is some amount of gut excretion. There is urate supersaturation, crystallization, and gout happens. Let's move on to hyperuricemia and the consequences. So biologically significant hyperuricemia is actually serum uric acid level more than 6.8, and it is less than what some of the labs, now they have changed, but initially the labs used to have a cutoff 8. I'm still at 7.5, but 6.8 is where the pathological consequences happen. And this is the hyperuricemic cascade: tissue nucleic acids, dietary purines, endogenous purine synthesis contribute to uric acid. But if you have hyperuricemia, more importantly, it's not the overproduction, it's the under-excretion that is at fault. So you have silent tissue deposition, you have gout, you have renal manifestations, and cardiovascular events and mortality, which will be, if you are lucky to have Dr. Viveka, I think we'll hear from him. Now, gout, it is derived from the Latin word gutta, which means drop, as it was believed poison falling in drops into the affected joints caused gout. A chronic kidney disease is a comorbid condition that affects, based on estimates, between 47 to 54% of patients of gouty arthritis. If you do your EGFRs, you'll find that about half of these patients have CKD. Now let's look at the relationship between hypertension, cardiovascular disorders, and gout. The recent prospective studies have confirmed that hypertension itself is associated with increased risk of gout, independently of potential confounders like dietary intake, obesity, diuretic use, or renal failure. The renal urate excretion was found to be inappropriately low relative to the GFR in patients with essential hypertension. So that's what raises the uric acid levels. Thereafter, what happens is that there is reduced renal blood flow, increased renal insufficient vascular resistance, which further contributes. And hyperuricemia and hypertension may reflect early nephrocirrhosis, implying renal morbidity. And hyperuricemia is also associated with incident hypertension or cardiovascular disorders. So these are the correctable factors contributing to hyperuricemia: obesity, hyperlipidemia, ethanol intake, diuretic therapy, poorly controlled hypertension, high urine consumption, and decreased urine flow. So this is one of a dialysis patient, and as you can see, both the elbows had capacious gout here. Now, when you think about uric acid in kidney disease, one is reminded of this word research. And 5 years after you leave a medical school, everything that you were taught will be wrong. Especially if you have the younger people telling you that this is what is common literature. But if you wait for another 5 years, it will be right again. So old is gold. And this is exactly the same thing has happened with hyperuricemia and kidney disease. So initially they said hyperuricemia caused kidney diseases, then they said no, it's totally harmless, bystander, don't even touch it, and now the wheel has turned the full circle and we are back to managing hyperuricemia and disease. So let's take a look at uric acid and chronic kidney disease. Is uric acid a risk factor? Association between hyperuricemia, kidney disease and cardiovascular disease dates back first to 19th century. Data from physiological and observational studies suggested an interspersed relationship between uric acid, CKD and cardiovascular disease. And in humans, hyperuricemia has been found a risk for hypertension, and in laboratory animals for proteinuria, leading to hypothesis that this could promote initial kidney damage or its progression. And this is what we learned when we were doing our graduation, post-graduation, including my supervision, and then things started changing. 1986, this was editorial in one of our leading publications, Kidney International, and it was titled, it was our Beck et al., Requiem for Gouty Nephropathy. And what they said was that significant association between hyperuricemia and so they said that this is harmless bystander. Don't even worry about it. But this study by Belomo, 2010, what turned the wheel in a full circle. They said no. Beck was not right. There is a significant relation with hyperuricemia and worse renal outcomes, both in general population and non-diabetic high-risk population. Again, a leading journal. So see how things are changing here. And these are, so I'll share with you some of the other studies now. Experimental studies have shown that uric acid is linked to arteriolar disease, so it causes arteriolar damage. And treatment of asymptomatic hyperuricemia may be beneficial in terms of reduction of blood pressure and kidney function. Gout leads to gouty nephropathy. In fact, there were 2 landmark studies by Feig and Johnson in adolescent children with hypertension. And what they did was they just treated the uric acid levels and the blood pressure was normalized. So that showed that they were the first to postulate that hyperuricemia in adolescents causes hypertension in the early stages. In the late stages, there is irreversible damage. There is another study, the MDRT study, a landmark study in nephrology. They said that the patient with stage 3 to 4 CKD, hyperuricemia appears to be an independent risk for all cause as well as cardiovascular mortality, but not kidney failure. So more confusion coming in, and we will continue that. Hyperuricemia and chronic kidney disease is due to decreased excretion here, and during renal failure, the intestines actually pick up and excrete and excrete some of the uric acid partly. So let's look at CKD. So this is a schematic representation of the uric acid generation pathway coupled with fructose metabolism and mechanism of resultant hypertension and renal disease. So you have the purine nucleotide degradation, this goes to AMP. You have the fructose here, which again is broken down by fructokinase. So we have adenosine, adenosine, hypoxanthine, xanthine, finally producing uric acid. The purine, this is the endogenous route here. Again, now animals, most animals have this enzyme called uricase, which breaks down to uric acid to allantoin and it is harmlessly excreted. That's why most animals don't develop gout. But in humans, we don't have this enzyme. So what does uric acid do? It causes inhibition of nitric oxide synthesis. It causes reduction of endothelial dysfunction, and this is actually a prelude of hypertension. And there is stimulation of renin-angiotensin system activity. So this results in hypertension. Again, so all this results in renal disease, induction of oxidative stress. So here we have hypertension, here RAS pathway, arteriolar constriction, interstitial macrophage and T-cell infiltration, renal vasoconstriction, ischemia resulting in kidney disease. Now this is, I think, something we should pay more attention to, and fructose is there in almost all our beverages. And this is what Feig and Johnson actually first thought discovered that there was this uric acid coming in from this, adolescents, and they found that it was it's a very cheap sweetening agent, and a lot of sweets also contain this, and so this we need to. Whenever you see hyperuricemia, think fructose and think of these beverages and the sweetening agent that is being used. So this is another study published in Nephrology 2010. So after the 2009 study, this came in. And what they found was that with rising quartiles of uric acid, so this is the different quartiles of uric acid. Highest uric acid here, intermediate, mean is 11.1, 5.5, 3.6, 1.8. So percentage of chronic kidney disease increased. 11.9% there as the percentile increase. This is 5.3, 5.4 to 6.4, 6.5 to 7.6 and more than 7.7. Highest incidence of chronic kidney disease here. And this is a study published in Journal of Epidemiology of the need to control uricemia and chronic kidney disease. Again, they essentially validated what this other study said, that the risk of renal failure rises with hyperuricemia. Greater the hyperuricemia, higher the renal failure. The two studies telling us exactly the same thing. Again, validated another study published in American Journal of Diseases 2004. So see how the scenario is changing from 1986, 2009, then 2010 onwards we start having these studies which are questioned, and they said that hyperuricemia actually predicts end-stage kidney disease. This is another study came out in 2011, very interesting. Nearly 1,500 type 2 diabetic patients with normal renal failure without overt proteinuria for 5 years were followed up for the risk of incident chronic kidney disease. 13.4% developed incident CKD. Cumulative incidence of CKD was greater in patients with hyperuricemia. 29.5% than in those without hyperuricemia, just 11.4%. So diabetic patients, hyperuricemia, treated, not treated, those who had hyperuricemia developed chronic kidney disease. So this concluded that in type 2 diabetic individuals with preserved kidney function, hyperuricemia is an independent risk factor for the development of incident CKD. And then this is, as I told you, he gets done a lot of work, a normal mediator risk from CKD, several studies which have essentially looked at uric acid and chronic kidney disease and validated it that it is a risk factor. So uric acid mediated hypertension is attributed to renal vasoconstriction. Vasoconstriction results in upregulation of the RAS system, and hyperuricemia correlates with both endothelial dysfunction, plasma inactivity, and both the above factors over time will lead to microvascular kidney disease. Last we take a look at urine therapy. So we must keep in mind the non-pharmacological therapy. Diet part is very important. Avoid red meat. So these are to be used very sparingly. So butter, red meat, pasta, sweets, white rice, potatoes, white bread. Then come your low-fat dairy products, high-fat dairy products as usual, fish, poultry, eggs. If you are looking at liquor, wine is, as you can see, neutral. Beer is high uric acid, so should be taken with a bit of moderation. Again, vitamins do help in antioxidant consumption. Try and take whole grain foods. Take plant oils rather than especially olive, canola, all these oils help. And obviously daily exercise and weight control helps you reduce uric acid. So gout treatment we all know. NSAIDs we use, high duration shorthand, you can have the renal failure, steroids, colchicine, all this has been used. Chronic management, and this is where xanthine oxidase inhibitors, they use allopurinol for a long time, but you have to modify this dose in renal failure, and there is always this risk of Stevens-Johnson syndrome. So Vixostat has the unique advantage, no dose adjustment, and I haven't seen Stevens-Johnson as ever since I have switched from Vixostat. And you have the other uric acid drugs, correct other factors like weight loss, ketone production, hypertension, and this is a comparison between Vixostat and allopurinol, the dosage used, and definitely far more safer drug to use, no major drug interactions, predominantly excreted by the liver, so no dose modification. These are the adverse effects, so just monitor for liver dysfunction, and nausea, arthralgia, rash are the other things to look for. Very rare in your 40 mg dose, but 80 mg you might find more of rash. So just keep in mind that we have seen picked up occasional patients who develop a rash, so you need to end up stopping it. So what about acute uric acid urate nephropathy? So sudden obstructive precipitation of uric acid crystals in the renal collecting system, usually observed in patients shortly after neoplastic disorders, more by our oncology colleagues. So they use prophylaxis with uric acid lowering agents, aggressive hydration, but it can cause acute kidney injury, and we used to we have dialyzed occasional patients. So allopurinol, chronic uric acid nephropathy, again, history consistent with chronic uric nephropathy is progressive renal failure in a patient with coexisting gout or uric acid nephropathy which has no identifiable factors. And this is a study of 11,408 consecutive autopsies in Switzerland. 37 revealed urate deposits, 3 of them had otherwise unexplained renal failure. So, uric acid stones, as we all know, 10% of the total stone burden in the US is uric acid stones. Yeah, because of lower urinary volume, hyperuricemia, and acidic pH, all predisposes. So fluid and dietary modifications, allopurinol, uric acid, and alkalization of the urine help in this. Immunotherapies is uricase. It's an enzyme, as I showed you now. It's been commercially made and it's available in the US, not yet in India. 2 other molecules in the pipeline and some monoclonal antibodies to target uric acid levels. So to sum up, this is in end-to-end comparative studies. Pembrolizumab has shown equal uric acid lowering activity equal to that of 300 mg daily of allopurinol, but pembrolizumab 80 is definitely more potent. On evaluation of summarized trials, it is evident that selective treatment with pembrolizumab is indicated in patients who exhibit sensitivities, and it can be administered safely to patients with chronic kidney disease. So to conclude, it's becoming clear that the role of uric acid is no longer confined solely to gout and nephrolithiasis. There is increasing evidence points now to a significant relationship of uric acid to hypertension and renal disease. And recent studies have started to unveil the causal nature of this relationship both in hypertension and renal disease. And we are now using uric acid lowering agents. The moment we have seen hyperuricemia, and there is additive improvement in kidney function. So hyperuricemia, to conclude, is a bad impact on kidney heart joints. It can be prevented as well as treated. Treatment needs to be lifelong. Pembrolizumab is the same molecule called xanthine oxidase inhibition, much more safe, much more potent. So let's come back to the story of Gadias. What happened there? Well, the cause of death here was actually gout because of toxin-induced renal failure. So there was one toxin which was hyperuricemia, which was renal failure. The toxin was there in the Chambal water river. It was effluent from some of these industries, and that is what resulted in the death of these Gadias. So I end on this note from an ancient Chinese medical test, and it is the superior doctors who prevent the disease. Mediocre doctors treat the disease before it is evident. It is inferior doctors who treat the full blown. So if you thank you.
Thank you, Dr. Gulati, for an excellent insights into the uric acid metabolism.
Paul.
Into
आवाज़ नहीं आ रही हैं
सुनाई दे रहा था
इधर आ जाओ
साड़ी करना दी वैल्यू ज़्यादा है
इधर ही
थोड़ा वॉल्यूम बढ़ाओ यार सर आप जो नहीं कहते हैं वो भी सुन लेते हैं
not just an inert end product of purine metabolism, of the metabolism of adenine and guanine. It has a causal relationship with hypertension, renal disorders, cardiovascular events, and gout, of course. So, it has a causal relationship with these and needs to be treated. I think the house is open for questions.
सर रिक्वेस्ट ऑफ ऑल डॉक्टर कादर सर प्लीज कम हाँ डॉक्टर खुदार our surgeon
Dr. Gulati, so according to you, asymptomatic hyperuricemia should be treated, and if yes, then at what level? because of associated hypertension and you said even renal failure.
So I think that's a very interesting question. Pure hyperuricemia. As of now, there are no very good trials. But if there is a hypertensive patient with hyperuricemia, if there is a diabetic patient with hyperuricemia, I would certainly treat it. If there are associated metabolic factors like dyslipidemia, again you would treat. But if it's, let's say, about it, I would try and follow up this patient.
So no comorbidity, simple
No
hyperuricemia you would like to
comorbidities. I
treat.
would just give him dietary
Even if it is 9 or 10 leveling.
I would give him some dietary counseling, leave him for a while, but put him on follow-up.
When feloxostat was introduced, there were some cardiac issues. As far as I remember, long time back. Yes.
There were some trials that said that allopurinol is going to be better in cardiac cases. Yeah, that I think Dr. Viveka may be a better person to answer. We have used it because a lot of CKD of chronic cardiovascular disease. I have used it very safely in all these patients. So I think it was just a one-off study that probably survived.
Thank you.
Very good. Sir, your topic was very important. And often we have values from labs where we have uric acid 8, 8.5 and 9. Patient is asymptomatic, doesn't have any problem. Would you like to treat an asymptomatic patient of a uric acid of 9 milligram with febuxostat in a diabetic, and for how long?
So if it's a diabetic, the answer is an absolute yes, because I showed you the 2011 study. So that changed the scenario. And you are going to protect or prevent kidney disease if you are able to intervene at that stage.
How long to treat, sir?
Maybe lifelong. Just
Are you targeting any uric acid levels?
yeah. So below 7.
Below 7. If we achieve that, let's say after 6 months, would you still continue to?
I would, unless, so my this thing is, unless it falls below 5, I keep them, because a lot of times you stop at that, they tend to rebound back. So my target is about 4.5, 5. If it stays below this, then I definitely reduce. So a lot of times they bounce back.
Uric acid has been a very debatable topic. Some people treat, some don't treat,
Very good.
with different outcomes. What is your approach to treating uric acid or hyperuricemia in a non-diabetic?
So, in a non-diabetic individual, as I said, if he is hypertensive, again I would treat. If he's got a family history, I think if there are comorbidities, dyslipidemia, obese, then you might still, err on the side of caution. Probably in metabolic syndrome, you need to give. That's what I would say.
Sir, when febuxostat was launched, and a lot of companies came with it. Sun Pharma was amongst the first ones to launch Febuca, and I think it is their flagship molecule, apart from Sompras. There have been issues of, and Dr. Podar mentioned it, there have been issues with febuxostat, especially of thromboembolic complications. Your experience on that and your advice on that?
So, at least in my experience, I don't really recall. We have used febuxostat extensively. I would say about 80% of CKD patients are on febuxostat currently. You see that they're in practice. And that I have not really encountered. It might be a rare side effect that we definitely need to watch for.
And the best thing is that you don't need to lower the dose of febuxostat. It's so safe in CKD patients as compared to allopurinol.
Very good. Sir, another question is, when we treat patients with cancer with chemotherapy, and these there are a lot of medications which raise uric acid.
Absolutely.
Sir, in that case, when a certain patient gets referred to you, and he or she is asymptomatic because of hyperuricemia, what is your approach to these patients?
So differently, I think these patients, we add uric acid level. lowering agents in these patients. And a lot of these patients come to us when they are referred to me that creatinine is usually sitting about 1.4, 1.5, and the moment you correct the uric acid level, the kidney function improves dramatically.
So, Dr. Chauhan, irrespective of the initial uric acid levels, all psycholytic drugs if you give, you have to give uric acid as a prophylaxis.
Whenever you are expecting a tumor lysis syndrome,
You did start them.
whenever we are expecting a tumor lysis syndrome and a high uric acid level, we should start uric acid lowering therapy even at normal uric acid level.
Sir, a lot of my physician friends were asking me when I called them for the meeting today that if we have a patient of hyperuricemia and if we start febuxostat, once on febuxostat, always on febuxostat?
So, unless you are able to correct, let's say you started febuxostat, this is a patient who's overweight, this is a patient whose diet is, totally on the top end of the pyramid as I showed you, and if he is able to reduce his weight, if he does some dietary alterations, you may be able to stop febuxostat in a subgroup of these patients.
Right.
Dr. Chauhan, sir, can I just comment? I'm just commenting.
Let's have a public opinion.
I'm commenting only, I'm not asking.
Sir, we will come to you. Sir, you are the master.
Myself, Dr. Vimal Kumar. I am the secretary of IIT South Delhi branch. Sir, can we start febutage in pediatric patients and how safe it is? If the drug of choice is allopurinol or febutage?
In pediatric patients.
Yeah, pediatric patients.
So there are no good studies in children, but personally I've used it in adolescents, and I tell you my reason for using it is the safety. I don't know how often you see, I have stopped using allopurinol or almost, unless somebody develops a habit, because we used to see about one patient of Steven Johnson a year, and if you see one of it, you have had it. So, but ever since we have been using febuxostat, I have not had any admission with the Steven Johnson till date. So that's another reason. In adolescents, the answer is yes. In children, younger children, data is not there. So if you are, one of those evidence-based medicine guys, you'll probably say, okay, I'll wait for the evidence. If I am there, I will use it in a lower dose and just make sure that things are.
Thank you, Dr. Saab. It was so nice. And you are so great gentleman, and I have been knowing you from past 15 years. Sir, my question is, I'm a Kashmiri Pandit, and we are having very high protein diet.
Yeah.
And approximately 80% of the patients from Kashmiris are having this problem, hyperuricemia. And my question is it hereditary? Is it related with diet? Because my father, my uncle, all maternal uncles, they were having the problem with the uric acid, and same is with me. I am hypertensive and diabetic, and I am taking febuxostat. My question is, sir, what should be the diet alteration? Because at the end of the day, I am diabetic. I'm on a very strict diet only. I am very loose when I come to CMEs with Dr. Tulsi. Practically approximately 3 to 4 times a week. I am having high diets, but usually in the morning I don't have any breakfast. If I have breakfast,
Dietary advice.
yes.
Dietary advice.
So dietary, first of all, I think the other question is probably interesting. Genetic, is it genetic? The answer is probably yes, because as I showed you, it is not your dietary intake, it is more your lack of under-excretion which is the culprit. So perhaps genetically, there is some gene, and in times we might get one, which is leading to reduced excretion of uric acid and high uric acid levels. Now, the second question is diet, as I showed you, yes. The diet is, because you can't treat the under-excretion, you can't do anything about it. So better treat the intake part. So intake, look at your fructose containing foods. Stop beverages altogether.
Sir, what beverages? What beverages?
By beverages, I mean all these
Soft drinks.
No, sir, I tell you one thing. See, I think
One question.
sir, it's my personal experience. I'm diabetic, I'm hypertensive, and I'm hyperuricemic. Sir, जिस दिन मैं मटन खाता हूँ, उस दिन मैं अगले दिन चलता हूँ।
Meat was at the top of the
And जिस दिन मैं काली उड़द की दाल, कोई भी दाल खाता हूँ, उस दिन मैं अगले दिन चल नहीं पाता हूँ। पनीर में नहीं होता कुछ। नहीं, कोई प्रॉब्लम नहीं। जिस दाल पीता हूँ, बिल्कुल फिट रहता हूँ।
सर पनीर से कोई इशू है?
माइक सर, पनीर से कुछ नहीं होता।
vegetarian diet, no rule.
I tell you, the day I eat mutton, it's a problem. The day I take dal, it's a problem. But the day I take normal diet, कुछ फर्क नहीं पड़ता, बियर हो, विस्की हो, कोई फर्क नहीं पड़ता। और विस्की तो बहुत अच्छा लगता है।
ठीक है, Dr. Let's move on. Dr. HP, you have a question? HP.
सर जब तक ये वहाँ पहुँचेंगे मैं सिर्फ एक कमेंट करना चाहता था डॉक्टर चौहान ने अलाउ नहीं किया नहीं मेरे को कहने दो। मैं कविता नहीं सुना रहा हूँ, मैं ये कह रहा हूँ कि जब कोई जहाँ शोर ज्यादा हो रहा हो तो जो ज्यादा शोर मचाते हैं उसको मॉनिटर बना देते हैं। आज डॉक्टर तुलसी को मॉनिटर बना दिया सवाल।
Competition in the market. Competition of allopathy, homeopathy, Ayurveda, naturopathy, blah 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 blah. Yes. The question is, against the allopathy, there are so many tenders, especially Baba Ramdev. My question is, Baba is everywhere, every pathy, every system, everywhere. My question is, sir, the Baba, whatever he is treating, whatever you are treating, the uric acid, whether your uric acid is increasing or decreasing, that's my question.
Sorry, you have to repeat your question.
Baba black sheep, have you any good?
Please, sir, this is not answer. Otherwise, I will ask again question.
Dr. SP Singh, you had a good question to ask. Unfortunately, there is no good answer to your question. Sir, please, thank you. Since Dr. Viveka is unable to make it, please handle in a case with a VIP. Therefore, very few chances that we'll be able to make it. I tried to arrange online this thing. He's still busy in the cath lab. I would request Dr. Tulsi sir to highlight the importance of uric acid in metabolic syndrome. Okay, we suffer from the epidemic of metabolic syndrome. Sir, your views on that.
Okay, thank you, Arun. Indeed, a great pleasure. So, friends, what's metabolic syndrome? You must have one of the three, you see, criteria. If you are diagnosed with metabolic syndrome, you have the following things: waistline of 40 inches or more in males and 35 inches or more in women.
90 centimeters in males and 80 centimeters in females.
A blood pressure of 130 by 85 or higher, or taking BP lowering medicines.
135/85 Lalit. Okay? 135/85.
A triglyceride level of 150 or more and reduced HDL level. These would be the criteria. Apart from this,
Any level of HDL, sir?
so probably less than 40?
Yes. Less than 40 HDL.
Right. So apart from this, may I add probably microalbuminuria and hyperuricemia as well? If you have, a metabolic syndrome, that will also constitute this.
Sir, great. I'll just interject. Once you have a low HDL is a surrogate marker of insulin resistance. Please understand. If you have a low HDL, it indirectly means that your insulin resistance is high, right? And one of the bottom lines of metabolic syndrome is insulin resistance. Remember this, low HDL is directly related to insulin resistance.
And hyperinsulinemia as well. Now, Dr. Juan, from an innocent bystander to to a really central player is what hyperuricemia today is.
Great.
We are talking about.
Great.
It was an innocent bystander, Dr. MK. Now a major contributor.
Yes.
So in causing metabolic syndrome, ASVD, atrial fibrillation, heart failure, coronary artery calcifications, arterial stiffness, fibrotic remodeling, and kidney disease, as Dr. Gulati said. So, what do you say? Also higher inflammatory markers, higher, cytokines like IL-6, IL-8, IL-10, tumor necrosis factor, alpha. Dr. Alexi would know. It causes beta cell apoptosis as well. And the European Journal of Internal Medicine just last month, 2022, also talked about the role of microbiota and altered microbiota and low vitamin D levels as well. So now there is some controversy, Dr. Chauhan, about whether feruxostat is CV safe. Does it increase CV mortality, all-cause mortality as well? See, I'm talking about a little about probably a recent study, see, which the Mayo Clinic proceedings, which talked about increased 20% heart failure hospitalizations with feruxostat as compared to allopurinol. But they also said, the Mayo proceedings said increased CV mortality and all-cause mortality as well. But a major European trial, the FAST trial, Dr. Bala, welcome sir. So they said in 2019 that there are no safety concerns. So we are not sure. See, one study says probably increase CV mortality, increase all-cause mortality with feruxostat. Another study says no, there are no safety concerns at all. Now, what else? Of course, I'm forgetting the SGLT2 inhibitors. Gulati, they reduce uric acid. See, by increasing uric levels. So, by excreting uric levels. So, another, armamentarium we have is the SGLT2 inhibitors, and I wish Dr. Gulati would have talked about that. Probably we'll talk about that. And what else? Now, I'd like to ask Dr. Gulati, he said that, not to ask, but just one or two questions. So, Dr. Gulati, would you say probably the progression of kidney disease and the risk factors reduce, that if you have high serum uric acid levels, is that a marker of reduced kidney function?
Definitely, you will see that in most of the situations, the moment you reduce your uric acid levels, the kidney function also improves. So that's why I said that currently we target uric acid level very aggressively. And I think yes, SGLT2 inhibitors definitely a recent addition to our therapeutic armamentarium. Marginal decrease of uric acid levels are asked.
So, friends, everything good or bad about hyperuricemia? My last question before we ask Dr. Mangla. What about hypouricemia? See, level, Dr. MK, level of less than 2.0 milligrams is probably hypouricemia. And it's seen normally in neurodegenerative disorders like Parkinson's disease, like Alzheimer's disease, motor neuron disease, LMP, multiple sclerosis as well, and certain cancers, sarcomas.
Also in syndrome of inappropriate ADHD.
Absolutely, absolutely. And they said, a large cohort study said that a negative relation between gout and Parkinson's disease persists. So, a lower, probably a higher uric acid levels would be neuroprotective. I end my talk here.
Thank you, sir. Let me, sir, before someone else comes and snatches my forte. Yeah, I will give, sir. Less numbers or say lower level of uric acid, lower level of creatinine lower level of urea, they may mean protein malabsorption also, because if you are not absorbing protein, but where you will get the metabolites. So we may have to see if there is any reason to believe that one person is taking less protein or there is any malabsorption of the protein.
So you mean to say that hyperuricemia could be a harbinger of a chronic disease?
Yes, malabsorption or less intake of protein, like we have in so many others.
We are talking about neuroprotective effects of hyperuricemia.
I am coming to that, sir. One school of thought is that uric acid is an antioxidant like vitamin C.
Absolutely.
And the other is just it can add to the oxidative stress. So we have to be watchful what we are dealing with. So my one level, as it was asked by Dr. Bodar also, there is no defined level when to treat if one is asymptomatic. So one has to find whether there are comorbidities. And sir, I would say, and my question, and by saying that arthralgia was less than 40 milligrams versus 80 milligrams. This is not explained. Febuxostat given 80 milligrams had less arthralgia.
It's a very marginal difference reported in studies. So I don't think it's a clinically significant, but yes, it can occur. It's just to highlight the fact that it has arthralgia. So if you have started uric acid, patient is complaining of arthralgia, you might as well step back for a while. If you are, but more importantly, I have seen more of rash, to be honest. The moment patient triggers complaint of a rash, we do end up stopping this.
Right, sir.
But
Dr. Gulati, TB is so rampant, and all age groups, and paracetamide is a very important drug. Usually 2 to 3 months it's given, and it invariably causes hyperuricemia. How much hyperuricemia is responsible for the joint pain caused by paracetamide? And whether all patients, earlier when we studied, we were not told to reduce the uric acid levels, because as you stop the drug, they will get better of their own. But at times the uric acid levels are 15, 14, 15. And if the patient is asymptomatic, should it be a part of the therapy or what level?
15 is exactly, hit the nail on the head. 15 has to be correlated with the toxicities and precipitation. So 15 there is no doubt that you have to treat. The doubt is about 10. Nobody knows that, whether you should be treating or not. If there are symptoms, perhaps you would end up treating.
But so much of paracetamide given, and at times the rifampicin is not tolerated, or in MDR-TB, I think this paracetamide continued for 2 years also, and some of the patients with rifampicin drug-induced hepatitis or some other side effects, paracetamide is continued. Usually, we stop it at 2 to 3 months. The guideline is 2 months, we stop at 3 months. I stop at 3 months. Not many pulmonologists stop at 3 months because the TB is a dangerous disease these days. So, should all these patients be given Febutas? Because invariably the uric acid levels will be 8, 10 in these patients. And all the same, all these TB patients are not ending up with hypertension or CKD. So what would you say?
Same, I think I would apply the rule of comorbidities. If there were a lot of comorbidities, I would end up. Otherwise, I also don't see a lot of tuberculosis in the CKD patient. We don't treat, every patient. So yes, if they have increasing worsening of renal function, we do end up stopping paracetamide also, or treating hyperuricemia in that sense.
Most of the patients with treating TB, I think their comorbidities get better because TB being so toxic illness.
So then the priority is treating.
So would you say at what level in with paracetamide therapy should you add Febutas, or the drug is going to be stopped after 2 to 3 months, so might as well hold on?
That's the practice.
Do you think this hyperuricemia per se is responsible for paracetamide-induced joint pain?
The answer is it may be. Paracetamide-induced joint pain, the hyperuricemia, and the proof would be lowering the uric acid levels and trying and see. If it is not getting better, then a lot of them are vitamin D deficient, so whether vitamin D deficiency is causing these joint pain is not relevant.
10 level, then 10 milligrams should be the level.
Maybe. Sir, my last question to you, Dr. Sanjeev. Uric acid is more strongly associated with kidney disease or with metabolic syndrome?
Metabolic
syndrome.
And hypertension.
And hypertension. Sir, I was expecting this question from the audience. One of the good antihypertensives and the ARB that we have, which reduces uric acid, is losartan. So if I have a hypertensive with hyperuricemia, should I shift my antihypertensive treatment to losartan? Then it is quite effective.
Telmisartan actually increases uric acid levels. If you've seen all your telmisartan patients, that uric acid levels are hovering on 7.5 or so. So yes, if you have hyperuricemia and you're planning sartan, definitely losartan.
Thank you, sir.
Actually, okay, would always help. Dr. Smalley has a question.
Small question. Sir, about losartan, I want to comment.
We call it
About losartan, usually people are giving 50 milligram once daily, which is a poor dose. It has to be 50 milligram twice daily or 100 milligram once daily.
At least.
Otherwise, it won't be effective. It has only 8 hours of action.
Losartan has a better action given twice a day.
Yeah, twice a day is a month.
Dr. Sunil Kapoor, sir.
So, does metabolic acidosis worsen hyperuricemia?
Not really. I'm not aware of. Maybe yes.
Then congenital oxidase, xanthine oxidase, congenital xanthine oxidase deficiency. That is one of the reasons of gout.
Yeah.
So how often do you see that and how do you handle that?
Maybe my practice again, it's a nephrology practice, we have not seen too many of those. I think they are being managed mainly by rheumatologists.
And lastly, so it's believed that you should treat high normal calories also, because that person could be having a low baseline, like 6.6, say 5.8 or 6.8, and 6.8 or something, and the person could be having a original baseline of 4.
No, I would not mention therapy there.
Thank you.
Very good. Sir, friends, we had a wonderful session, and we apologize on behalf of Dr. Viveka. He is still held up with his VIP case. He has never missed an appointment with us in last 17 years. Today was the first time, and we understand that he must be really busy. I would request Dr. Vaisi Paul sir to summarize this CME for us, to take home some important messages which you must have in your mind before we wind up this session.
So uric acid is not an inert product. It can cause problems, and if it is high beyond a certain point, in certain situations like in associated diabetes, associated hypertension, even if the person is asymptomatic, we should treat it. And febuxostat is a good medicine, because the other medicine, if somebody has seen a case of Stevens-Johnson syndrome, you always remember it for a lifelong. So, and it was a good question answer session also. Most of the questions have been answered. So thank you, Sanjeev. Thank you,
Since we don't have Dr. Viveka and we still have Amuke left, it was my original intention to felicitate